Yep.
All right. Well, why don't we give this just a few more minutes here for some other folks to join, then we'll get going. So this was actually a real case from a while ago, and was a case of a patient who, obviously, as the case went, came in, and everything is sort of true as far as how that went, as far as resting right through the double duet squad doors and that type of thing. So it's pretty wild.
That video I sent
Happened.
you, I actually, that was exactly the same thing that happened to us. We got the report this person was coming in short of breath, and then they were doing CPR when they got there. That's the one we opened the chest on.
Oh, the one, yeah, the one. And I did not put your video in the presentation. I sort of was thinking I was sort of short and like the amount that it showed, but I definitely think it'd be interesting if you talked about that.
Oh, yeah,
So
I will, because there's a relevant section when we talk about thrombolytics and in PEs, and why that probably wouldn't have worked in this particular case, but it's a great idea when they're not totally obstructed. It'll tie in nicely, I think.
good. All right, so I'm going to stop sharing our sort of pre-roll there, and we'll get this party started. So thank you to folks who have joined, and this is our chapter 6 of the Bouncebacks Critical Care book, and very excited to join a fantastic group of panelists, which I'll introduce in just a second. I just want to make sure everyone knows that there are no disclosures as far as anybody having a conflict of interest. We'll flash the QR code for this 1 hour free CME. I'll also say that this being the 6th of the chapters, between this one and the other chapters, we've had almost 1,000 people view this either live or off of the recorded videos for the enduring materials off the website. So very, very exciting stuff. And these cases are all true. The documentation is true. There's been some minimal changes, obviously, for patient confidentiality, and sometimes just to augment some of the teaching points and all. But without further ado, I wanted to introduce our very, very fine expert panelists here. We have Don Yealy from the University of Pittsburgh, who is the chair there. And Don is not only a emergency medicine physician, but also the but a specialist in critical care. And he was the section editor for this section 2 now that we're in, the 5 chapter sections of the Bouncebacks Critical Care book. I'm excited to introduce Ben Trotter. He is the chair of the emergency department at Adena, where I practice. And Ben was actually a resident in the same hospital and had a very rapid ascent into chairmanship and has done unbelievable work. I shouldn't really be announcing this to the world because, Ben, they might steal you from us. But taking a group that was a lot of transition and really made a stable and fantastic group that gives great emergency medicine care. We have KK Moody, who everybody knows here as the founder of EM Docs, the Facebook group, which has about 30,000 members, which is pretty amazing. And then Colin Kaide. And Colin and I have worked together for years and years from the Wexner Medical Center and the Abercrombie and Fitch Emergency Department at the Ohio State University. That's your joke, Colin. So I had to sort of plagiarize a little bit there. So thank you guys so much for joining. What I'm going to do is I'm going to start by sharing our PowerPoint here, and I just wanted to tell you this one is just going to be a tiny bit different than as we have done in the past. And the way that it's going to be a little bit different is that we're going to spend a very, very brief amount of time talking about the first visit here. We're going to really very, very quickly delve into the bounce back visit. So let me pull this up here and make sure we're on the right one here. Yep. So this is the disclaimer for CME purposes. And there's the barcode at the top. If that's too small for your phone, which I would pretty much guarantee that it won't be because phones are amazing, here's the larger QR code so folks can shine their phone at that. If you've not already registered with EADS, you basically just need to put your name and your email address, and that's the whole thing. It should take less than 15 or 20 seconds. So I'll keep that up there for a second, and then you get an hour of free CME for that. So fantastic. So let me do this. I'm going to start us off right here talking about this initial visit of the patient, and we're going to have some discussion points here. Then again, like I said, we'll very quickly delve into the bounce back visit. This one is also sort of unique, is that the patient's initial visit was not at an emergency department, but we'll still have some pretty good emergency department teaching cases. So this is the documentation. This patient went to her OB office, and she went for basically just like a, well-checked sort of continuity type of visit. But interestingly, and you'll see down towards the bottom here, that the patient complained, and this is under review of systems, and they documented this, reports lower extremity pain and plans to follow up with the primary care provider. I'm not exactly positive what PCM stands for, but being true to the actual documentation, we put that on there. And then interestingly, this is a little bit of foreshadowing here too, is on the patient's on her physical exam, the vital signs showed that the patient was tachycardic, which was actually recognized by the clinician. In the sense, under the cardiac exam, it does say tachycardic, and they say under their impression, well-appearing 36-year-old female, follow-up for a pap smear, urine beta, HCG, etc. So before we go into things further, I want to just take a little bit of time and just explore, and it doesn't really matter whether it's at a OB office or an emergency department. People come in with a primary chief complaint, maybe a question they're asking. I have chest pain. Am I having a heart attack? But then oftentimes there'll be associated complaints. And sometimes there'll be that, as we always make the joke, when you're walking out the door and you have your hand on the doorknob, when they say, how about this elephant sitting on my chest, when they came in for an ankle sprain, right? So we're not transcriptionists, we're historians. However, sometimes there are findings that we can't just ignore and say, follow up with your, PCM, whoever that would happen to be. So Ben, I wanted to start off with you, Ben Trotter. You know, we are seeing patients with chief complaints. You're doing follow-up visits as the chair of the ED, patient complaints. How do you reconcile, not only in your own practice, but also as part of some of this quality control process, reconcile a chief complaint that's addressed, but maybe an associated complaint that's documented, but is not addressed?
That's a really good question. I think the hardest part about what we do is we get very focused on the patient and what they're presenting with and their, concern, and then taking care of that. And we always worry about the life-threatening illness that we're either dealing with or potentially missing. And what patients tend to write in for, at least in our area, is that they felt like they were rushed, or that we didn't take into account the entirety of why they presented to the ER. And I think all of us are very good at reading that room and knowing what the actual issue that's going on is within seconds to minutes of being in there. But the patients really need us or want us to give them that time. And I think that's a big change for what we do in emergency medicine now from what it may have been years ago. Is that patients want to have that primary care office experience in an emergency setting, and it's very difficult.
Yeah, I remember 1995, it was sort of like, we're just putting out fires, we're making a decision, admit or go home. But now it really is, the expectation is that you actually have to make a diagnosis. I'm not saying that we didn't have to back then, but you're right, it's a lot more of that. And sometimes even just asking the question, have I addressed all your concerns, could be something that would maybe preempt a patient complaint like that later. So Colin Kaide, you work in a large, enormous academic center, the Ohio State University, and obviously there are all types of complaints that are coming in, and sometimes getting to what the patient's concern is or their patient's presentation's question is can be sort of difficult. And then I'll sort of throw this out to Don after you answer this too, but what is your process for making sure that all serious complaints are addressed?
Well, in this particular situation, it's a little different in that this was an OB office, and this came up as an incidental thing in the review of systems. If I was seeing this in the emergency department, my guess is that the chief complaint to me would have been leg swelling, in which case we would have proceeded down that pathway. Now, if when I'm doing my review of systems, I'm asking additional questions and they say, oh yeah, I've been having chest pain, I don't think I would gloss over that. Or maybe to make a good analogy here, let's say they come in with in the review system and say, oh, I've been having very heavy menstrual bleeding for the last 5 years, and I would probably consider looking into that a little bit, looking into a CBC and maybe say referring them to get tested for maybe even von Willebrand's disease, which is often unrecognized. So you do have to pay attention to those things. I can see why it would slip by here because she's not going in with a complaint, with a real complaint. She's here for a wellness check with her OBGYN. So it'll get missed. It shouldn't have, but I can see why it would have in this setting.
And in all fairness to patients, sometimes we discover something on the exam that wasn't discussed in the history, and we need to go backwards. And we always want to be looking forward in our lives, right? Mostly in our lives in the emergency department, and not going back, especially with the concern for patient throughput and patient satisfaction, et cetera. So, Don, most folks, actually more than half the folks, myself included, on this call have been the chair of, moderate to large to very large emergency departments. You are currently the chair also. Let's sort of go back just a little bit, because certainly we don't want to make misdiagnoses, but no one wants that sort of nastygram from their chairperson of a patient complaint. And as a chair, you don't want to be wasting your time or your vice chair person's time with answering all these patient complaints. Wrap all of this up in a bow for us as we conclude this discussion on the initial visit with some really big take-home points from your career.
So let me summarize for you what my current job is. I oversee 40 emergency departments, 9 urgent care centers as the chair of emergency medicine. So that's
Wow.
about 1.5 million visits a year across the Commonwealth of Pennsylvania, New York, and Maryland. And then as chief medical officer, I took over about a year ago. There are 6,000 physicians and probably 4 million visits a year that roll up. And so with all of that, I have a heightened awareness about certain things. The point I would tell you here, no matter where this was, what the complaint was, we take things called vital signs. We don't call them physiologic signs. We call them vital signs because they're important. And in this particular case, you had one that was abnormal. I see in practice that there are 2 errors that happen. One is you're just blissfully unaware of the vital signs, just like you're blissfully unaware of what the nurse wrote on her intake. By the way, that's with you for the rest of the visit and everything that happens afterwards. And so many of our trainees and partners just link to those things without ever really having looked at them. So that is opportunity number 1. And then number 2, when one of them's abnormal, you and I are in the sensitivity business. We don't want things to slip by, particularly life-threatening things. The next thing to do is, after recognizing it, measure it again. If it goes away, you can go on with the presumption that nothing is else. But if it's still there, you have the opportunity to intervene. So what I see is either absence of the information or failure to actually address it and or assess this. So in this particular case, you have a pulse of 118. If after talking with this patient, it was 82 without intervention, I don't have any issue at all. This is just true and maybe unrelated. But if it's still there, this is actually a fairly profound difference in pulse rate. It would be hard to just ascribe it to trivial issues. So make sure you know what they are. That's why they're called vital signs. And 2, if one's abnormal, just measure it again and see where you're at. It's the failure to do the simple things that will always bite you in the butt.
An important to follow up on that. Our residents and are trained, and we in emergency medicine, we don't let people leave with abnormal vital signs without doing exactly what he said and rechecking. But I frequently have to remind people who are rotating in my department that, and I would imagine that most OBGYN residents aren't thinking along the lines of, you can't go home tachycardic unless I can explain it. And so I think our training is very different than what they have.
Yeah, of course, certainly we're thinking about that more specifically. And just what Don was saying, that look, we have people come in all the time. They're 200 over 120 blood pressure, and you check in, it's 120 over 80. I mean, I know there's other data on risk of hypertension, et cetera, diagnosis later on. But the point is that that recheck that you said, Don, is just so absolutely, so vitally important, because 118 heart rate, you check it again, it's 80, pretty reassured. Check it again, it's 132. All of a sudden, maybe even in the OBGYN office, that patient is not going home. So those two abnormalities were not really recognized. They certainly weren't put into the impression of plan. We're not here to give commentary on the care given by gynecologists. As far as a brief overview of thromboembolism, because it's sort of in some ways the question that the presentation, although subtly, was asking, is that almost 500,000 people in the United States every year have some form of a VTE, and 200,000 people diagnosed with PE every year, which increases with age. So younger person may be a little bit less likely in all comers, but there's certain demographics, specifically people who have had a malignancy, people maybe who had some sort of immobilization or cast or splint recent surgery, or some sort of oral contraceptive, hormonal therapy, et cetera, would be at higher risks of that. But we certainly want to be aware, because this, of all of the things we do, would be one type of very significantly preventable illness. So this tachycardia was discussed, and we've talked about this in the past, but one of the more famous studies is by David Sklar, University of New Mexico Health Sciences Center, where they looked at almost 400,000 patients over 10 years. And of the possible error cases, they found 1 per 10,000. So 35 possible error cases of patients who died an potentially avoidable death within 7 days. Of those cases, 71% of those had unexplained tachycardia. So that unexplained tachycardia, not the dehydrated patient or the person in pain, but the unexplained tachycardia who is discharged still tachycardic, does represent a pretty high risk for us. So what happened to our patient? She went home and she was just fine for about 3 weeks. Again, every single person with a DVT, assuming that is what she had, and we'll sort of find out about that soon, does not die from that, of course, even untreated. But she then developed shortness of breath and called the paramedics. Paramedics had the patient, they brought her in, but coming through the double bay squad doors, the patient arrested. Paramedics yelled out, "We just lost the pulse." The patient was rushed into the nearest available room, where all the ACLS type of protocols and maneuvers were all started. So what I wanted to do is throw things back to Ben, and I'm going to ask you, in a rural setting without ECMO, what are some, not just the medical student version of ABC, start from scratch, what are some pro tips on patients who present an arrest, some mistakes that could be avoided, or some pro tips that we could use to take best care of our patients in that situation?
So all of us kind of go back to what we know or what we lived or grew up with, I guess. So my background comes with a lot of sports and then sports psychology. So when we were developing our management in our health system for cardiac arrest or codes that come into the emergency department or even within the hospital, we started at the foot of it and had all of our nurses and staff that are participating in these trained in the same way. And so all of our staff are taught ACLS through the same manner. That goes from day one. So anybody on the floor or in our emergency department will be doing the same process or knows the same process. And then that carries into how we do it in the emergency department. So then that staff is then educated on what the expectation is while in the code room. And so that helps a lot in how we are able to give high quality care or consistent care while running those codes. And then within our emergency department, we've also been very active in how our physical footprint is within the department. So we have side-by-side trauma bays that mirror each other, that have identical equipment in them, that are accessible and known by everybody where they're at. And so what's important to that in the performance of a code is that anybody in that room knows exactly where any device is. Any staff member that's participating is able to run that code if the physician weren't there. And for me as a physician walking into that room, managing a patient who's critically ill or dying or dead, I can have the cognitive offload of all those other what ifs and maybes that we typically may have to manage. And now I get to think critically. I get to take in the big picture, see what's going on. And like in this case, maybe have the opportunity to think about that this young girl has a PE as opposed to some other source to her, cardiac arrest that we're treating. And so for us in a rural setting, without those other wonderful, medical management things that come from the academic centers, or at least not to us yet, we really focus on making sure that our team is available and easily accessible and has resources within the room that everybody knows how to access.
And it's really pretty cool because in some ways the staff runs the code as far as the ACLS protocols, leaving time for the physician to do either procedures or to do that critical thinking like you're talking about. So KK Moody, you have been like totally neglected. I apologize and unfocused on you this whole time. But this next question is directed to you. And we don't have to sort of go through how we manage each of these, but just to keep in the top of our brains, and we talked about PE arrest as being one special circumstance that could occur. What are some other reversible causes of cardiac arrest that we want to really be thinking about at the bedside?
Yeah, so no worries about ignoring me.
No.
My photo's not there. I apologize. My video, I can't seem to get my thing to work today. Maybe it's just because it's sympathetic that I'm post nights, and maybe it's telling me something that I
The
should not
universe,
be
right? Yes.
seeing. But I completely agree with what Ben just said about having consistent care and back to the basics and having everyone in the room think about these things, especially just in a code. Sometimes the code is the simplest thing for us because we have such algorithms, and it's important that we remember to not forget about those algorithms, kind of back to the basics, all the H's and T's that we learn in medical school and residency, the hypoxemia, hypovolemia, hydrogen ions, are they acidotic, hypo or hyperkalemia, hypothermia, do they have a tension pneumothorax, a tamponade, a cardiac tamponade, toxins, thrombosis, like if they have an MI, do they have a pulmonary embolism, but also do they have a pacemaker failure, a ruptured aortic aneurysm, dysrhythmias, trauma, sepsis, intracranial hemorrhage. I mean, the list goes on, but what Ben said is so relevant because having everyone in the room to pick up when you're doing the central line or when you're thinking about what is reversible that I can act on right now.
And it's sort of funny, like thinking about all those H's and T's, like tonight, maybe isn't that hard. But in the middle of a code situation, it's not even the code, but the fact that you have 20 of the staff that you work with watching you, it is nice to have that designated amount of time to think without having to, try to keep track of the fact that the last epi was 4.5 minutes ago, right? So Don, I'm going to direct the next one back to you, and I'm going to have a couple of follow-up questions for you also. But I mean, obviously, years of training experience with all of this. So lack of cardiac activity on a ultrasound that we're doing in the ED, and of course, we're going to want to try to do that very quickly, right? But just sort of walk us through, obviously it's not good, but walk us through what we should do with our ultrasound findings in the midst of a patient who is pulseless during a code.
Great question. We all know that in a group of people without ultrasound identified cardiac activity, the prognosis is grim would be the kindest way to put it.
Yeah.
And that a group who had some activity would have better outcomes. Mind you, the amount of crappy outcomes are really pretty high in both groups. So the differences here are fairly modest. The whole point of the ultrasound, much like the previous two discussants did, is to try to find something that's fixable in addition to prognostic information. And so the prognosis is aided by this, but it's not determinative. What are the other factors? How long has this been going on? What was the pre-morbid, essentially pestilence or comorbidities? 45 minutes into cardiac arrest with someone with stage 4 New York Heart Association heart failure, diabetes, and previous stroke. The additional information from the POCUS is actually not, if they're still pulseless, is not going to be particularly great. what we need to do is put things together, and it often requires, it's almost like playing three-dimensional chess very quickly. Where do I think they're at? What do I have that I can fix? And when I don't, as you said, fall back on the algorithms, have preset intervals that you're going to actually make determinations about things. In this particular case, you have a younger woman who ostensibly doesn't have a whole lot of other illness burden, either acute or chronic, up until the moment of events. So her timeline differs from, for example, mine, or me with pancreatic cancer would be even worse. I'm a little older than the patient. There's no magical number about it. Those are really how I would approach this. We have the busiest post-cardiac arrest service in the country at UPMC. And what I can tell you is I can give you predictions in groups of people. It doesn't predict success of the initial resuscitation all that well in any one person. In other words, you and I might be able to restore some cardiac activity. Whether or not they leave the hospital is a whole separate other question that requires a little bit further downstream input.
So I'm going to ask you two follow-up questions, and you're welcome to answer these in either order that you'd like to. So lack of any activity, does that mean to you instantly stopping resuscitation? And I'll put it back to our patient that we have, who we actually have a witness arrest, not witnessed in the field, but witnessed sort of by us in our own emergency department, right? So that's the first question. And the second one is, you have 30 minutes of chest compressions and epinephrine and all the things, and you're ready to call the code. You figure you take one other quick look and you see the heart is still beating. Not that well, but it's still sort of moving. You can't feel a pulse. How does that factor into calling a code? So sort of two diametrically opposite situations, but I'm really, really interested to hear your thoughts on both of those, because those are, I think, both tough situations.
Yeah, I think, again, the ultrasound is an important piece of information. You're asking me, is it determinative just in isolation? The answer to that in any one patient is no. In the former patient, lack of the first one you asked about, lack of cardiac activity, but with a fairly short arrest time in a younger person means that you actually have the potential to restore some of that. And so I would not treat it as just stop here right then and now. If you had told me that same younger woman and it was 45 minutes into the arrest, yes, adding the incremental benefit onto observed failure and no responsiveness, I'd stop at that point, but it wouldn't just be the POCUS alone. The converse is interesting. You and I are mature enough to know before POCUS was around that the other thing would be is somebody would put the monitor on after 40 minutes of CPR.
I knew you were
and
going there.
see some sort of deflection off
Yes.
and it would be like, oh my God, can you just stop that, please? I want to be done right now. So again, I would not use the ultrasound as a singular tool in that area. But would it tell me, had I really exhausted all of my efforts? I would ask myself, what was left in the armamentarium? It is a powerful but not a determinative tool in both cases, in my mind.
And I'll tell in a little bit of a self-deprecating way, Don, you don't have to admit if this has ever happened to you, although you're welcome to, of the patient who you pronounce, and then 5 minutes later. And since that time, since that one patient, like 25 years ago, it was always like, man, I'm listening to this heart for like 60 seconds, 120 seconds. That will never happen to me again. That was not a good experience.
Yeah, but what we all know is that person who gets some sort of sign of life back after you gave up, they don't go home.
No.
It is just an incredible moment of embarrassment.
Yes, that's exactly what it was. Right. Okay, so Colin, you know, not the 36-year-old woman, but just another branch point. I mean, we know that there's a lot of heart disease in the country, and a lot of people have heart attacks, and a lot of people have cardiac arrest. So it sort of makes sense that a lot of those, now I'm not talking about the drowning victim or the trauma victim, but the patient who arrests at home, so common that this would be from a heart attack, right? Would it not just be useful to give everybody that has a cardiac arrest a thrombolytic? I mean, it seems like it would, but the data suggests otherwise.
Yes, exactly. You'd be tempted to do that in terms of saying, well, if this is occlusive disease and the person is perfusing, thrombolytics do have the ability to take care of clots from MIs. The problem is when you actually look at it and when it's been studied, there's really been no significant difference between in circumstances where TPA was given versus placebo. And that study came out originally in 2008, and I haven't seen anything to contradict that yet. So in all comers, I would say definitely it doesn't make sense. The caveat is, and I think you alluded to this, if you have a situation that doesn't make sense to you, like a 25-year-old or a 30-year-old or somebody with a known DVT, let's say that they come in cardiac arrest, that's a different picture because that is a subset of all cardiac arrests in which you have a theory that this might be due to a large embolus. In that case, I would consider doing it without proof that they have a PE. However, in all comers, I think that that's a done issue.
Yeah, and so
And
the study
Colin,
that
I
you,
think,
oh, go ahead, Don.
Colin, I think the thing is, if you're going to have these thoughts, got to have them early and act upon them.
Absolutely.
It's the same thing as, is calcium in cardiac arrest helpful? No, except if they just brought you from the dialysis center. It might be the absolute first thing. So there is occasionally some pretest probability in the research on systemic thrombolytics was done at a time in which they were delivered almost as holy water at an extended interval. And of course, the benefit, you would need incredibly large numbers to show even the most modest effect. So it's one of those things that if you're thinking about it, and as you said, the circumstances tweak you, it's something you got to act upon. 20 minutes later won't be the time, because at that point, it doesn't matter why they went into cardiac arrest. The cascade of internal pestilence has run amok, and it's going to be very hard to fix.
Yeah, for folks who want to take a look, the study that Colin was talking about by Bodiger, thrombolysis during resuscitation for out-of-hospital cardiac arrest, New England Journal of Medicine, 2008. No significant difference in the primary endpoint, 30-day survival, hospital admissions, ROSC, 24-hour survival, survival to hospital discharge, or neurologic outcome. So really, of all of those, it seemed like this was pretty much the study that put that to rest, which is why we don't really do that anymore, or if we ever did. So what I want to do is tell you about what happened here. And the CPR was continued by the code team, and the patient was intubated. She was noted to have bilateral breath sounds. It seemed like the tube was in good place. They saw it go through the cords. And so at that point, we move now to decision point B. But I'll tell you, before that even happened, the patient's husband arrived. And the code leader spoke with the husband, who said, and filled in a little bit more, that in addition to the patient having shortness of breath, which was the reason for calling the paramedics, she'd also had some unilateral leg pain that she'd been complaining about for the last several weeks. So this was obviously a big concern, and it brings us to number 2, and Don had sort of talked about this a little bit, but decision point B here. And we're going to go through each of these decision points, find out that the actual provider did, talk about it in a literature-based fashion, then move on to our next decision point 2. But, you know, Don, we have everything from a young person without any other great reason to the patient who, you know, was just brought from the 2 days previous when there's a surgical suite, has a cast on their leg, and has a history, according to the family, of thromboembolic problems. I mean, this huge spectrum. So obviously, before we even think about using lytics for PE arrest, and Colin's going to talk about that in just a second, when do we even suspect a patient? And we'll talk soon also about how long we need to circulate that thrombolytic. So it's a big commitment to giving a patient thrombolytics. But in which patient do we suspect it enough that we'd really consider giving a thrombolytic?
It's a great question. I feel like Willie Sutton when asked, why do you rob banks? And it's because that's where the money is. So obviously someone who has already had recent venous thromboembolism is, that would be top of your list. Number 2, if they haven't had it yet, but have some or many of the features that would put them at predisposition, you'd think that. And then number 3, and this was said earlier, particularly in the younger person, when something just doesn't fit, ask yourself, let's be honest, a 36-year-old woman, in my entire career, 35 years now, the number who had an acute myocardial infarction as a primary cause without some other, without having a crack pipe at the same time too, is infinitesimally small. So I'd be asking myself what else could be going on here now. In this case, the husband gives you a story that is, crying out for venous thromboembolic disease, maybe not diagnosed at that moment in time, but it's right there for you. I don't think you should be thinking about this 45 minutes into a failed resuscitation from the field. At that point, it's a cocktail conversation. It can't really drive a meaningful intervention. And with the deluge of patients in whom these other things we talked about aren't present.
So Don, I don't know there's something about you that really makes me want to ask follow-up questions. Maybe it's your years of experience and expertise blending together, but can I give you a couple of scenarios and we can just do like a Fisher cut bait sort of moment on those. How about a 36-year-old who had knee surgery 2 weeks ago with no other medical problems and no swelling of their leg? Is that a patient that you would give? We could just do like a yes or no. I could give you a bunch of these, but is that a patient that you would give thrombolytics to who's presenting an arrest?
Yes.
Okay. How about a 75-year-old who has a history of malignancy, but no history of any sort of thromboembolic type of problems?
Which malignancy and how long have they been in arrest?
Okay. All right. You're throwing it back to me now, I see. um, let's say it was a witness arrest at home and they have a history of lung cancer and they've had 2 rounds of chemo with minimal responsiveness to it.
No, I would not do it in there. But if you had told me a shorter arrest and pancreatic cancer or a CNS primary tumor, yes, I actually probably would be thinking about that. Yeah.
Okay. All right. Well, those 2 are probably enough just in the interest of time. But it always to me is the more interesting thing, not even necessarily the giving of thrombolytics, but which patient we would do that on, because absolutely, I sort of view that analogous in some ways to giving thrombolytics for stroke, whether you believe in it or not. If you're going to do it, no one believes in giving it a long time in the future, right? So if you're going to do it, you got to do it quickly. And of course, I think we're all pretty much doing it these days, right? So Colin, this next question has been up there here, and you have some data. It's not amazingly great data that anybody, not just you, but anyone in the world has really. But tell us about the use of thrombolytics in PE arrest.
Well, again, as you said, that there are some decent studies that have looked at this. Sharifi et al. In the American Journal of Emergency Medicine 2016 gave TPA to people who had a confirmed massive PE, and they got ROSC within 2 to 15 minutes in 22 out of 23 patients. So that almost seems too good to believe. But it shows that if these people have the right circumstance, they might be able to survive this. Another study that was done that was out of hospital cardiac arrest caused by PE, and I'm not sure how they knew that 100% coming in from the outside, unless they magically could tell that it was there, or maybe they went back and they looked and they made a subsequent diagnosis. 58 out of the 246 people who came in received TPA, and a 16% survival group in the thrombolytic group versus 6% in the control group. So that gives you some decent reason to think that if you have a confirmed PE or you strongly suspect it, it's a good idea. Now, I'll give you a couple of case examples that illustrate this point. I had a 50-year-old nurse come in who restarted herself on her birth control so she wouldn't be on her period during her vacation. And she came through the door after a syncopal episode in the lobby, tachypnea, tachycardia, hypoxia. We sent her to the CAT scanner. We got the images, and she had massive PE, and she arrested on us. And we had originally called cardiothoracic to see if they do an embolectomy, but we didn't have time to wait for them. So we pushed TPA, and we got ROSC back, and she lived neurologically intact to be discharged. That was miraculous. And the radiologist even called me the next day and said, look at her repeat CT. There was no clot burden.
Wow.
It was very impressive.
Colin, did you ever have a thought of giving her lytics before you sent her for scan?
We were getting ready. We were
Her
actually.
story is screaming
Oh,
for
yes.
embolism. That would be the play. I mean, that means you're committed to it. It's a high risk, but high yield.
They were mixing up the drugs as we were speaking. The second case was another one. This was a girl who had an ankle fracture, and she was in a walking boot, and she went into her orthopedic office for a visit, collapsed on her way out, and a nurse witnessed the collapse and saw that she was short of breath, called the squad, and we were told that she was coming in with a pulse and alive, and apparently she arrested in the breezeway and came in an arrest. And we put the ultrasound probe on her, and we saw two very interesting findings. The heart was beating like crazy, but there was no pulse and there was no transmitted impulse in her aorta, despite the fact that compressions were being done. So there was a complete 100% right to left block. We, at that point, we were thinking about this, and I thought to myself, if I give her thrombolytics, they're never going to get into her heart. They're never going to get into her lungs to reach the clot. So at that point, we actually opened the chest, my resident and I did, and did open cardiac massage and massaged the pulmonary artery. And I can prove this is true. I sent Mike the video of this actual resuscitation. But we, after massaging the pulmonary artery, the heart just started beating again. And the nurse said, "We have a pulse." And my resident turns to me and said, "Oh my God, now what?" And I said, "I don't know. I've never gotten to the pulse back in a medical arrest before." And she ended up going for embolectomy at the time and had two gigantic sausage-sized clots distally. So I think she had a saddle embolus that caused complete obstruction. I don't think TPA would have done anything in that circumstance. Whereas in our other patient who probably did not have complete obstruction, but had such a high clot burden that it caused her right heart pressures to be too high and she just failed. That it's a kind of a little different than having a complete circulatory obstruction. But I think we've emphasized this point enough. If the right circumstance exists, I'm going to use the TPA.
Those are super interesting stories. The second question, just in the interest of time, we can sort of go by. Obviously, we can give thrombolytics through a larger peripheral line, of course. And before we get to your point, Ben, I just want to let folks know that you could ask questions to panelists or comments. There's a lot of expertise and experience on this call here, so folks can certainly enter stuff in the chat. So, Ben, there's some controversy between the American Heart Association, some of the European guidelines, as far as after we give the thrombolytic, how long we continue compressions. So fill us in a little bit on some of the recommendations from the different guidelines.
Yeah, thanks for breaking that up after Dr. Kaide. I don't know if I could follow that one very well. Too good of a story. So yeah, you and I have been talking about this and trying to tease through the information that's out there, and there's no definitive yes or no or exact number that you or I could find. I've heard anywhere from 15 minutes up to what we were finding in some of the European journals, and that up to 90 minutes. So there's a wide range of what the expectation or thought would be for chest compressions after lytics being provided. You can make the argument based on the article that we were referencing here that 15 minutes would be more than enough, considering 2 to 15 minutes everybody got ROSC. But I think that the standard would be at least a prolonged amount of time for circulation, and giving that the most appropriate amount of time to affect the clot. And just like Dr. Kaide said, if it's completely obstructed, it's kind of a useless or futile effort. So it really does depend on that.
KK, the thrombolytics are given because of a strong or even moderate suspicion of PE. We get ROSC. Obviously, we know this is still a tenuous patient. What is your thought, and of course not a right or wrong answer in this situation, but your thought on post-lytic for suspected PE, ROSC, a CT scan to be done on that patient to confirm our diagnosis, or if it doesn't change management, better keep the patient in the critical care area, the emergency department?
Well, first, I just want to say I love the spontaneity of the cases that are coming up. This is this is an incredible discussion today. It's lively and I love it. So really, I think the CTA, which we can do triple rule outs for obstructive coronary artery disease and aortic dissection and pulmonary embolism, but I think the utility of this would be much better to have been done before the arrest. I think after we get ROSC, it can be used to confirm the diagnosis, but it's not necessarily going to drive the immediate post-recovery phase.
So I'm going to give you a rubber meets the road question, KK, holding your feet to the fire a little bit. You are the emergency physician, the patient arrests going through the door. You suspect PE, give the thrombolytics. After, say 20, 25 minutes, you get a pulse. The patient's still unconscious. He's intubated, of course. What are you doing? Are you sending that patient for CT or calling the ICU and setting her up there and saying, they can figure out, do it later that afternoon?
Well, in real life, I'm sending her to the CT if she's got ROSC and if she's stable enough.
Okay. Yeah, it's
So you
good.
just have to know, don't you? You gotta know.
No, I can't just call the ICU doc and go, you figure it out.
Well, and Kay, if you were looking for any more clot-directed therapies beyond what you did already, and that's going to be a partner who's going to be doing that, they're not doing it without a better assessment of the clot burden. And so we all know that people get sent to CT to die, but in this particular case, it would be very hard to see a way around that if you expected either catheter-directed ongoing thrombolysis, extraction through a catheter, or surgical embolectomy. Yeah, nobody would do that without more information.
Yeah, and frankly, this is different, just like you're saying, to the CAT scanner to die. This is a different situation because the patient's already intubated and, in sort of a morbid way, already was just dead, right? So arresting there or in the ED, I mean, at that point, after giving the thrombolytics, there's not going to be tons more to do. I guess you could send her for an emergent embolectomy, but as far as during a subsequent arrest, I mean, it's really going to be chest compressions. And as long as you have adequate staff at the CT scanner, I would do the same thing. Colin, you're our lone last voice. CT or send her up to the ICU?
I would CT. I need to know the answer to that question, and I think the rest of the hospital system is going to want to know the answer. I think
Gotcha.
on the line, the family's going to want to know the answer. And if I wait too long, as I pointed out in the case that I had, the next day the clot burden was gone completely.
Yeah. So that's exactly what happened as far as follow-up after discussion point B. The patient was sent to CT scanner, did reveal a saddle embolus, and the patient was then sent to the ICU. And before I tell you exactly what happens with the patient, because that's pretty interesting also, how about next question here. So Ben, going to send this to you. We've talked about this study in the past. It's really one of my favorite studies because it was just such a well done study. But this is a study by Lemke's talking about cathing, and not necessarily in the 36-year-old woman, but again, similar scenario as to the question that I gave earlier to Colin. Yeah, heart attacks cause a lot of arrests. So shouldn't we just cath every patient post-ROSC? Lemke's didn't really find that was the case. Ben, I'm not sure if you're muted. Let me pull you up here for a second.
Sorry.
There you go. Yep, all good.
So yeah, it's a really interesting study. It does a really good job of evaluating and comparing 90-day outcomes with a immediate angiography group and then a delayed angiography group. And essentially what comes of it is that both groups performed about the same, which falls in line with probably anecdotally what we'd seen over the years, but it did give us some help in the emergency department because we're not burdening our cath team and having to pull in all those resources during these events. And what it did show in there, I think if we just tease out a little bit of it, is that the delayed angiography group did have a better time to getting cooled, which, and we can talk about that in a different conversation, but at least for neurologic outcome and those things, it was more appropriate in that manner.
Don, we talked before about not seeing a heartbeat on an ultrasound as well as seeing a little bit of activity on it. But say this same situation, this 36-year-old, we're pretty sure that this is a PE. She has no other medical problems. She's had this leg pain for a few weeks, as told by her husband. She presented with shortness of breath. I mean, it's probably not an asthma attack, or a pneumothorax, right? So we give the thrombolytic and we circulate it. Say we even circulate it based on the European guidelines for, they say 60 to 90 minutes. Say we do 60 minutes and the patient still does not have really any evidence of life at that point. When are you stopping this resuscitation?
So for me, it's a time, duration of arrest multiplied by available options still for treatment. In this particular case, you're getting down to none. Also multiplied by the pre-arrest, essentially, health, which is not just an age issue, but age has a lot to do with it, comorbidities. And so you put those together. So there's some extremes, after an hour and a half, it does not matter why the arrest started. At that point, the cascade has run amok, and trying to fix one part of that, the clot part of it, is simply irrelevant. Conversely, a younger person, I would not stop this at 20 minutes. I would think that would be too soon. And I don't know that we have granular type of data like these to guide the contemporaneous decision making. So we all put our thumb up in the air and we do the best we can putting these together, those three factors together. That's how I would decide upon this. So in this particular case, I'd have gone longer. If you told me the same story again in a 76-year-old man with metastatic pancreatic cancer, I'd probably not go longer, for the idea that the likelihood of it wouldn't just be, can I predict ROSC, but can I predict a return to his previous level of health? And at that point, we know that that's not happening. It is simply just not happening.
So you know me, I've always got the follow-up stuff for you here. As long as we have you on the call, we want to make a total use of your knowledge here. I had a patient, this was probably 2 or 3 weeks ago, and the patient arrested, got it back, arrested again. And after the 5th arrest, the family had come in, and the family decided really spontaneously, as far as, not that I didn't give them guidance to this, but they questioned the futility of further attempts at resuscitation. So certainly putting the family into that also, but not in that standard sense of you make the decision. It has to be done with our own guidance. Tell us where you go as far as that thought that you have, but then how the family's wishes play into that.
I think if the family has had conversation and thoughts before the terrible event, it's incredibly informative and should be, if not determinative, it should be as close as things can be to that. I think it's very, very hard for someone who's never been prepared to think through this for the first time at the moment of truth. It's gruesome if they're watching it and trying to assemble the information. So I would, again, ask their input, but probably only do so at a point in which I was ready to concede that the futility was very, very high. You bring up a great point, is that if we can know about what the status is before the very first dominoes drop, that actually can be very, very helpful. The truth is we don't know that a lot of the time.
Colin, let's move on to our next question here. Sort of a little bit of a branch point. So we could talk about a massive PE, but not necessarily arrest. Compare systemic thrombolysis, which to me it feels like the speed with which you can give it is going to trump in some ways, a thrombectomy, unless people have your expertise that are doing the thrombectomy in the ED, Colin. So I'm guessing most of us are not really doing that in that sort of way. But our hospitalists oftentimes are reluctant to take those very, very significant PEs because they say, well, maybe they'd want to get a thrombectomy. And I have to say that, that is not a common situation in my 27 years of emergency medicine experience. To me, if the patient is getting something, they're getting systemic thrombolysis. But have you been able to compare the data on these two and to give some guidance as to, which we should move to before that arrest happens?
Yeah, there's actually a couple of articles on this. There is one in the Journal of Thoracic and Cardiovascular Surgery from 2018. And the conclusion in that article is that pulmonary embolectomy and thrombolysis are associated with similar early and long-term outcomes. There's another study that was done and just published in the Journal of, Journal of Endovascular Surgery in 2021 that comes out with the exact same answer. They're roughly the same. In my hospital system, I can call what's called a pulmonary embolism response team alert, a PERT alert. And when that happens, that is not to push the responsibility of deciding on thrombolytics in a person who meets the correct criteria to get thrombolytics. What it does is it offers a couple of other options. And one of them in someone who's not dying right in front of me actively, because that one I'm pushing thrombolytics on without calling anybody. But this allows for the person with the submassive PE or somebody who is a little bit less hemodynamically optimal to go to the cath lab and have catheter-directed thrombolysis facilitated by ultrasound and facilitated, and the idea of the ultrasound is to help break up the clot, more like a therapeutic than a diagnostic test. So I have those options. And when we had a cardiothoracic surgeon who was very aggressive about embolectomies, we did probably 20 or 30 embolectomies over a 5-year period. And that was an additional option for us. So whichever one is available to you is probably okay in the stable patient who has the submassive or a pretty significant PE with a clot burden. The unstable one, you shouldn't have to think very hard about that. If they meet the criteria, like a systolic under 100 for more than 10 minutes, persistent uncorrectable hypoxia, which is not that common. In those cases, those people, you should push the thrombolytics and not be afraid of it.
Yeah, in fact, with patients who have PEs and who do have a syncopal episode, maybe that would even factor in if they've had some sort of head trauma as far as, thrombectomy versus systemic, et cetera. But the speed with which you can get a thrombectomy, you page the surgeon, then they call back and whatever. I mean, having the alert set up like at Ohio State is a super helpful thing. So before we have all of us with our closing, hopefully very insightful thoughts, KK, we've now just been super awesome. We've thrombolyzed this patient. We've sent them over to CT scanner. We've shown that there's a saddle embolus. And in just a sec, I'll tell you what actually happened to the patient in our scenario. True story here. But differences in post-ROSC care for patients after successful thrombolysis.
Well, just like any patient with ROSC, you have to think about the whole body ischemic event that just happened. And there's a lot of tissue damage after the reperfusion. You have to focus also on the central nervous system and the myocardial dysfunction and the hypoperfusion and just the multi-organ failure that can happen. So that's just like any ROSC. But one of the main differences, in my opinion, is that you have to make certain to consider and to inform the intensivist about the possibilities for bleeding.
Yeah, and there is actually a significant percentage of patients who bleed, not surprisingly so, and less so percentage-wise or similar to minimally less than patients who get systemic thrombolysis for a CVA. So I want to, before we all of us give our last bit of closing wisdom, tell you what happened to this patient. The patient was admitted to the hospital, of course. She eventually had renal failure. She went on dialysis. She was in the hospital for 2 weeks, but the patient walked out of the hospital on her own with some minimal cognitive difficulties. But that was when she walked out of the hospital. I don't have subsequent information on her, years down the road, but the short version is that this thrombolytic, giving this patient TPA for our specific patient who arrested coming through the double bay squad doors, this saved her life and allowed her to, again, walk out of the hospital with just minimal cognitive difficulties. So thinking about, and I'll just give my sort of thought in the beginning here, thinking about those reversible causes, KK, like you talked about, and acting on them quickly, like Don talked about. I hope I didn't steal any of you guys' thunder there, are super important to do. So why don't we go around? In fact, KK, why don't you start us off with some sort of closing thoughts or practice-changing thoughts you'd have after our discussion here?
Well, I'm not sure that it's practice changing, but it is something that's kind of my mantra when I'm working with medical students. Vital signs are vital. Just never, ever, ever discharge someone with an abnormal vital sign without addressing it.
Love it. Ben Trotter, what are your closing take-home points here?
I think just the early awareness of what your patient is coming in with, and being able to quickly put all those pieces together so you can make the most aggressive decision possible for the patient when it's appropriate.
Awesome. Colin Kaide, give us some wisdom.
I think after all these years of giving TPA to 90-year-olds with stroke mimics, I have lost a lot of fear about giving TPA. And if I've got a young person who meets the correct criteria, loss of circulation, or I'm sorry, blood pressure under 90, or some people use 100. We use 100 in our institution for longer than 10 minutes. I have no fear of giving TPA to that person if I think either strongly suspect or know for a fact they have a PE. I'm not going to hesitate.
Awesome. Don Yealy, of so many great points, give us one or two.
Of all the terrible things that we worry about in emergency medicine, if you wait until you hit diagnostic certainty, it won't matter. This is meningitis, this is epidural abscess, this is ischemic gut, this is massive PE with arrest. You can search for metaphysical certainty, but your patient will die in the middle of it. When you're certain any of these things exist, it's actually already too late.
Thank you all panelists as well as the participants for joining. These have all been recorded. This is chapter 6. So actually chapters 2 to 6 were recorded. This one will be live tomorrow on the website. It's EM, like emergency medicine. So embouncebacks.com. And in addition, you can also sign up for our next book club on May 2nd. That'll be chapter 7, a 56-year-old man with shortness of breath. We are going to take the summer off. June, July, August, we will not have, and we will get back going again with chapter 8 in the fall. So thank you so much to the participants who have given us an hour of your time tonight. I hope we've been true to you as well. Thank you so much again to the panelists, Don Yealy, Colin Kaide, Ben Trotter, KK Moody. I'm Mike Weinstock, and thank you so much again for joining. We will look forward to seeing you all on May 2nd. You can register on embouncebacks.com. Well, guys, thank you so much. I think probably some folks might still be here, but really appreciate it. We can communicate in texting, but thank you guys again for doing this.
Thanks everybody for the experience. It's great education.
Thanks. It was great.